Good morning. Good morning, chairpersons and delegates. And Jagdish sir. Good morning. I am here to present talk on rigid bronchoscopy, and I will demonstrate few of the things on the rigid bronchoscope. So coming directly, because it is a skill development session, so we are not going to see any theory part. So we are going to directly see the practical part and how the things go with the rigid bronchoscopy. So these are like anesthesia is a part and parcel of the procedure itself. We need to have a good discussion with the anesthetist, good rapport, because we are sharing the same space. And anesthesiologist should know all these things beforehand, before coming and giving the anesthesia. So don't jump directly to anesthesia. The anesthetist should come to the theater and talk to you, talk to the patient, talk to the relatives, have the consent, and then only he is allowed to put IV line and all. Otherwise, the thing is not. So let him adjust. And one more thing is, you yourself should be there in the theater beforehand. So your mind, pulse rate, BP should come down to a very good level. Now, routinely, what is being done is sedation is avoided, pre-op oxygenation is desirable. If possible, bronchodilator by in the form of nebulization, if it is possible, and if child allows, should be done. The induction is usually preferred nowadays with the sevoflurane because it is very good, and in 3 or 4 inspiration or breaths, the child goes in a sedation, and then you can put IV line. Most of the times don't detach the child from the parents, because he starts crying, and crying exertion will increase his breathlessness and everything. So the best thing is the child should be in the lap of the mother. Then put the IV line if possible there and there, otherwise with the sevoflurane. And induction is as usual with the oxygen and sevoflurane. Small dose of propofol is preferred, and scoline. If the time is increasing, then you can go with the atracurium. Monitoring is with the monitor routine. My preference of anesthesia and ventilation is with Venturi, because it allows time and ventilation. Deoxygenation and hypoxia rate is very less, and you can monitor and do the procedure uninterrupted for quite long time. Only thing is, anesthetist has to, I have to ask the anesthetist that please stop the Venturi, I'll do something, and then again start the Venturi, means ventilation. And this is needed when I am doing anything in the bronchial tree. If I am catching the foreign body, removing the foreign body, doing suction, all this time, if the fragments are there, I'm going to ask him, okay boss, if oxygen saturation is good, let me do something. And the line where he should inform me is like 85, 80, 70. That time he has to just inform it is going down, so I can break and allow him to ventilate. There are ventilating and non-ventilating type of bronchoscopes. Intermittent ventilation can be done. Apnea technique is also possible. The problem is, apnea technique, the surgeon gets very less time. Intermittent ventilation, and again anesthetist is coming every now and then. So my preference of anesthesia and ventilation is Venturi. So this is the top one is a ventilating bronchoscope, and down video you are seeing is with the Venturi non-ventilating type of bronchoscope. So in short, you have 2 types of bronchoscopes. One is non-ventilating and other is ventilating. Now there are Venturi injector of different sizes, needles are of different sizes, and there are different modifications for that also. Now Venturi itself helps in so many ways. You can reduce or decrease the pressure depending on your desire from 60 psi, it may be 10 psi, 20 psi. There are regulator and you can reduce the pressure also. Venturi can be used to dilate the bronchial tree so that you can get the space for catching the foreign body, that is forceps space. Venturi is used to drain the secretions because intermittent venturi will drain out the retained secretions. Venturi disadvantage is smaller particles may dislodge deeper, so at that time you should inform the anesthetist, please stop venturi, I am going to catch the smaller particles. And rest of the monitoring, blood gas analysis and those things. Now, inadequate ventilation during scopy is an issue. Both should be having a very good calm mind. You should have an anesthetist who is well versed with your technique and your OT, and he is doing all the time these type of procedures. Stick up to 1 or 2 anesthetists, don't keep on changing. Don't invite new anesthetist. I train new anesthetist with senior anesthetist. So it is like a changeover or buffer sort of thing. Whenever there is inadequate ventilation, you always keep the scope 1 centimeter proximal to carina and have good ventilation. So that is a place to rest. Whenever you feel you are in a confusion, you are in a hypoventilation, you are in a hypoxia, come to carina. Carina is a place where you should relax. Why? You can ventilate the child. You can ventilate bilaterally, and then the oxygen saturation goes up. Now these are the another tips. If there is a bilateral foreign body, then also hypoxia may be there. Never ever withdraw the scope all the way in hypoventilation. Never ever withdraw the scope if bleeding is there. You can keep something there and still ventilate. If you are coming out and bleeding is there inside, you are doing more harm. So it is better that if left-sided foreign body is there, come to carina or right side, ventilate, wait, and then have a hemostasis in there and there only. By coming out, you are losing the control over the bleeding also. So there is no contraindication for foreign body removal. Now coming to the surgeon part, we need to have 3 or 4 scopes, 1 above and 1 below. Then forceps 2 each, suction cannula 2 each. See and practice the scope and forceps and duplicate foreign body if it is possible, and practice your hand, then coordination, the forceps before you do the scopy, before anesthetist comes. So this is your job. Prepare the trolley, sit there, have the scope in your hand, hold it, put the forceps, see that it is coming and you are doing. Put the suction cannula, see how much length you are going to get ahead. Then keep bronchotelescopes and pediatric sinoscopes handy, and endoscopic camera and all other things. 2 suction machines, 2 light sources, venturi system, then all other things you need to have at your disposal. Now this is something instrument. Now this I have brought here also, so that you can have a look on the same thing which is shown in the video. Now this is a optical telescopic forceps, bronchotelescopic forceps, which is going along with the scope, and the camera is attached to the scope. The forceps is a telescopic forceps itself, and then all in one assembly. Either you take out Along with the foreign body, if the foreign body is smaller, then you can remove the small foreign body through the scope. I'll replay it again. Now this is a ventilating Storz bronchoscope, which has a proximal fluox adapter which is movable. One side you can attach light cable, on other side you can have a ventilation port, you can block it or you can use it. Then this is a movable part which has lens and channel there. This is a broncho telescope with the forceps, and this you can pass through that and you can see the image on the screen. So these are different forceps. So this is a, you can all of you can have the look. This is a part which you can block here, and if you want to remove, you can attach the ventilation. This is for venturi. You can apply venturi here. This is a part which is fluox adapter, which sits here, and you can move it proximal and distal directions. And this side you have a light. So this is a ventilating bronchoscope. Why ventilating? Because you can ventilate also and you can do venturi also. So depending on both purposes can be done with this scope, because this has a nice attachment. You can block it. If you want ventilation, you can attach the ventilation, and anesthetist is ventilating. And when he is ventilating, you have to block this proximal area. Okay? And when you want to do venturi, then the proximal end should be open and venturi end should be open, and then you can do venturi, because with venturi the proximal end should be always open. Otherwise barotrauma can happen, otherwise emphysema can happen. So we need to understand this simple principle of venturi, where the atmospheric air is indrawn or sucked in. So along with the oxygen, the atmospheric air is going up. But it is not must that everybody should have this. You can still go or get away with your non-ventilating bronchoscopes also. If the oxygen is falling, it is better that you ventilate, and then you can definitely increase the oxygen level.
Where we get to suction, suction? For suction,
Here, in this there is one hole, here there is a suction, and here it is a magnifier. So if you just slide, you can pass the suction through this.
okay.
So this same adapter moves like this.
Without scope, na sir? Scope is in forceps. Scope is in forceps.
No, that time you are not going to do suction. You have to do suction. Take out the suction cannula, separate, and then have the telescopic forceps. So with the telescopic forceps there is no suction.
With naked, we can do the suction.
Now this is a telescopic forceps. So this is a broncho telescope. This is 0.9 millimeter by 30 by 40 centimeter. So this goes like this. The end comes here. This is locking. You have to attach the light here. So this becomes illuminated. The forceps are there at the distal tip. Got it? Now the camera is attached here, and you are seeing the image there. So your hand is going like this, but you are seeing and looking at the monitor and then catching it, and under vision you are taking it out. If the foreign body is bigger, then you have to take scope, foreign body and forceps together.
Comfortable with this scope or carry?
What has happened is the limitation with this scope and forceps is.
Out of 10 cases, how many times you will use this and how many times you will use collector?
My answer will be straight. Yeah.
10 out of 10 times.
No.
This will be in your almari.
No.
Ease of
Because
convenience is
now
with
what
the-
has happened is it is good for demonstrating, good
Yes.
for teaching, good for recording, good for presenting. Now what happens normally or practically is maneuverability with the forceps at the deeper level is difficult. These forceps are not sturdy for maybe tamarind or chiku seed or custard apple seed. So there they are not stout. So we have to resort to a normal forceps. That's how. Even if you know advanced technique, you need to know basic techniques also. Now what I am saying is, what I'll do in most of the cases, if the patient is very much hypoxic, I'll go with a straight non-ventilating forceps, look into it, take out the foreign body and remnant of the foreign body or second foreign body or recheck scopy, I'll do with the telescope. So that time I may not be or I will not be using this forceps. I'll be using telescope just to see what is called as the technique of scopy is inspection first, inspection, draining secretions, looking for foreign body, then extraction, and then re-inspection. So in a given patient, in a scopy, you are doing scopy for 3 times. Okay, 3 or 2 times minimum. So inspection, secretions, aspiration, looking for foreign body and preparing. Then extraction, removal of foreign body and completely getting out. And one more time you are going just to see bleeding is there, aspiration is there, double foreign body is there, remnant is there, and then the procedure is out. Okay. So there is any doubt about this? Answer to his question is, nowadays I am using this forceps less and less. Okay. And the reason is the maneuverability of this is very difficult. And the forceps, you cannot use these forceps below 1 year. The maximum incidence of foreign body is 1, 2, 3 years.
So
or
1
to
year,
one-
to be specific, below 7 to 8 kg.
7 to
8 kg weight.
weight wise. Yes, I thought of weight. Okay. So this is the instrument part which I eventually we don't have here to show you. Now what happens is, this was just the instrument part. Anesthesia part we have covered to some extent. Then instrument part we have shown how we can go and what you need to have. Now the technique part. So technique part is, you need to have left hand with the laryngoscope. Most comfortable way of doing bronchoscopy is, one can do without laryngoscope also. But the best way for everybody and most sure way is have the laryngoscope, routine laryngoscope, go in the valvula and see the glottis. Got it? Then afterwards, exscope them. Have the scope in right hand side, right hand, if you are a right-handed person. Exscope them. Bronchoscope कुठलं? आता सर चला बंद करूया. Sorry. So this technique part, what I was talking, if the child is here, head end is here, I am sitting here, I have a laryngoscope on left hand side, I have bronchoscope on right side. So two hands are working. So what happens is, you should hold the scope like this. Now holding the scope at the center, between index finger and thumb, and the middle finger is resting on the palate or upper teeth, anterior palate. So this is the holding position between these two, and 3 fingers are only working. index finger, middle finger and thumb. So you hold the scope at the center. So this much you can do. Then after seeing the glottis, you have to see that beveled end is on left. So all the time you are seeing left nuchal cord. So introduction of the scope up to the glottis under vision by holding at the center is done. Then at the glottis you just negotiate to some extent and then you can enter easily. The moment you enter, the laryngoscope is out. Then you have other hand free. Now change your hand. Now after changing, you have right hand free. Simple, these are simple, I am just putting it in words. So this middle finger is going to hold, you have to hold at the palate. And this will work for extension also with the finger because the patient is child. And now these two fingers, you can pass the scope gradually deeper. Got it? Now you have one hand free, the scope is stabilized, everything is good. Now once you reach Karayana, the straight is you can go to the street. Same, scope is held like that and you are entering the right bronchial tree. Once you have examined the right bronchial tree, withdraw it up to Karayana, then rotate it in 180 degrees and then enter into the left. Got it? Simple. And the procedure is done with one more hand you have free with the forceps, suction, anything you can do because you are holding this. Venturi is using. So at a time you can use the suction first, see the lie of the foreign body, don't touch the foreign body directly, don't disturb it if it is with the granulations, and then remove the foreign body. Removal, as I told you, if the foreign body is larger, you take out foreign body forceps and scope together. If it is smaller, it can be taken out. So once everything is out, again go in, stay there, ask the anesthetist to ventilate, get the oxygen level high, and till patient comes out, you can keep the scope inside. The moment patient is out and spontaneous respiration is there, anesthetist says now he is out, then you can take out. Other option is, if suppose patient anesthetist has given atracurium and long time, then you have to intubate again and ask him to ventilate and your job is out. Okay, so the anesthesia, best thing is never ever have a hurry to remove it because the once you remove you get no control over the air. Now whatever we have talked, we are just going to run through the slides in another few minutes and then any questions you have. So this I told you in just this is with or without laryngoscope you can introduce the bronchoscope. Then the way I told you how to enter right and left bronchial tree. These are my videos which are almost 20 years ago. So 20 or 20 years plus, and this is how the position is. This is how on the screen you are looking this is just a telescopic examination which I was talking about. This is anesthesia trolley. This small video laryngoscope, you are passing the, see how I am changing my hands. This video is there on YouTube also. This is just the inspection of the foreign body. This here highlighted inspection, extraction, re-inspection, so you should not deviate from protocol. In inspection, you are sucking out the secretions, seeing some granulations, but not touching and disturbing. Your job is out. Now you are preparing with the telescopic forceps. So this will be a extraction part of the foreign body. Go beyond the granulations, have a grasp for it, and everything you are taking out. As one unit. Once you completely extract the foreign body, you can go for re-inspection and again look for any granulations, foreign body, secretions, blockage, all you can do. Once this is over and patient is awake and out of anesthesia, at that time you can withdraw the scope. So these are the points which are covered in inspection. You can just read through if you want, because how the inspection, every small single step is important. Always have a look on other side also, because bilateral foreign bodies are known, multiple foreign bodies are known. Don't be in a hurry that okay, we have completed the job and great. Always plan the grasp. Don't be in a hurry. The moment you see, just don't go. You plan the forceps, technique, holding, rotation, so many things, because first grasp is always the best grasp. If you miss that, you are breaking it and then you are struggling it. Now there are so many things which we need to understand depending on the type of foreign body. If it is soft, if it is hard, if it is sharp, if it is metallic, if it is whatever, impacted, with granulations, without granulations. So all these matter when you are planning for removal of foreign body. Forceps space is a space you need to understand around the foreign body and distal to the bronchoscope tube. You need to understand how much away my scope should be, how much space I get for forceps to enter and extract. If the foreign body is slipped from your forceps at the glottis or in the bronchial tree, again repose it and have another grasp. Now re-inspection is for foreign body, second foreign body or remnants or suction of secretions. So this we have covered. This is post-op care lights. So any questions? Because I was more on a technical part, so I was more focusing on that part. So regarding technique or removal or any questions or practical importance, anybody who has?
Putting the scope in left bronchus is not easy job. So what maneuver do you do?
Yes. Then if I am on the center of the table, if I want to go to left, I'll shift my chair to the right side of the table, head end. Okay. Then my scope is rotated to 180 degree, so that the axis becomes straight. Then I turn the head of the patient to right side, so that my axis, all the time I am thinking in mind that my axis should be straight, because I am handling a rigid tube, and that too in a child. So going on the right side is easy, straight you are going, because it's larger and shorter and straighter also. But going on left, come to the carina, shift your chair to left side, right side, so that you are going to left. Then shift the head slightly, turn to right side. Have slight extension if you need, and then see that you are never ever force the scope without under. It should be always be under vision. Never ever force with the in a blind way. Unless you are seeing distally, you are not going to insert it also. So that answers your question, I think. One is shifting your place, shifting head and turning 180. And then your axis is extremely straight. Then if you are going in a lower lobe, you can slightly lower the head also. Anybody?
So what is the success rate? I mean, not succeeding. What is the success rate
Of
removing of the foreign body? And if not succeeded in some difficult foreign body, what to do?
so success rate increases with time in the years.
Sir,
The rate defines initial, beginner, intermediate. So success rate now is very high, but to me. But for beginner, I am telling you, sometimes the situations are very difficult and you feel really depressed on yourself. The thing is, if you are not able to remove, put the foreign body there and again go in maybe 24, 48 hours later. So this is one. Stopping or abandoning the procedure is done if anesthetist says, if patient's condition says, and if the foreign body and around situation is not very good. So you can try and attempt, there is no issue. Second scopy is done preferably with one more ENT surgeon involved or one more scopist involved rather than you going in, because the patient also is more convinced that my doctor is taking one or two more doctors to help my child. Okay. So I'm not saying that you should not do, but it is always better that you have one more guide.
Sir, is that you?
One more scopist, endoscopist.
Sir, with
Tell
the,
him you will not pay him.
No, I need to pay him full.
with this Kalilka scope, which anesthesia technique, intermittent apnea technique we use or not?
I use Mentcon because with Kalilka scope also there is a side port for doing. I showed you in one of the days. In Kalilka scope also at the proximal end there is one tube out, and through that you can put the venturi needle because proximal end is already open.
And sir, what are the limitations of rigid bronchoscopy over the flexible one?
This has different implications. That has different implications. Foreign body bronchos in a child always and
Use it for diagnosis.
always rigid because you cannot do with a solid flexible scope. Flexible scope has a role of seeing it, examining it, diagnosing it, ruling out the foreign body, taking out the bar if it is negative, removing the mucus. So flexible is done when the diagnosis is in dilemma. Pediatrician, parent and myself all are in confusion. Put the flexible scope, see the bronchial tree. If it is not there, no rigid scoping. Okay. If flexible scopy shows that there is no foreign body on either side, then you are through. And
It goes up
then if
to
it is
bronchus only. It goes up to bronchus only. The
Yes.
left and right bronchus, not beyond.
no, it can go to the subsegments. Means say for example, right middle directly you can visualize, right lower fourth you can visualize. Subsegments. Right upper and left upper is you don't have a curved forceps. You have a flexible forceps and it is very difficult. And foreign body itself will go in a lower side and main bronchus. Very rarely, if the patient is vomiting and in prone position, then it can go middle lobe. Very rarely, it can go to the upper lobe. If it is patient is unconscious or some other thing. But otherwise, they are in the main bronchus or in the lower lobe.
Sir, last question. While doing bronchoscopy, when it takes time, longer time, and patient saturation is going down, then what will you do? That intubation or our time the procedure or what?
Saturation is that body inside is not going to get cured. Okay. That time you have to come out, but the escape should be safe. Coming out should be safe, isn't it? You
If there is
cannot-
a laryngeal edema and everything is sedimented,
Hello?
how will it come out? Then how
No,
will it
laryngeal
get-
edema will not be there, because with this type of technique nothing will happen except the laryngeal or subglottic or upper tracheal foreign body can have laryngeal edema. That you have to resolve with whatever steroids, oxygen and everything. And last measure for that would be tracheostomy if needed, but that should be last class. You don't have to do that because laryngeal foreign body sometimes can induce edema and then you have a tracheostomy, but that is a very rare situation.
Okay.
Laryngeal foreign body usually have a sudden death on the spot, and
Hello.
very few reaches you. They reach you means he is going to survive.
Hello. Thank you.
Thank you, sir, for the wonderful session.
What to do for the granulation if the
Hello.
body is embedded in the granulation?
Yes.
Hello, we
That's a
have.
nice and practical question. I'll answer in a.
Yes, sir, yes.
First thing is, once you understand there is granulation, you prepare your mind that your anesthesia is going to extend, your time is going to extend, and then at that time, don't be in a hurry. Ask the anesthetist ki take 10, 20 minutes more. Have one in 10,000 adrenaline saline swab, hold it with your faucet, with the scope, under vision, decongest those granulations, then do suction, give some time, again do decongestion of those granulations. Once you see that the granulations are becoming less or decongested and foreign body is safe, then try to remove the foreign body. Okay? Very rarely you need to remove the granulations and then foreign body. This is very rare situation. But as long as you are seeing the tip of the foreign body, then this is the perfect way. And after removal of foreign body also you can apply some xylocaine or adrenaline 1 in 10,000 on the swab. Keep it there and remove it.
Thank you, sir.
Thank you, sir, for the such wonderful session. I request chairperson to felicitate Dr. Shyam Somani, sir. Okay. We will have next lecture on stroboscopy by Dr. Prashun Mishra, sir.